Welcome back. I'm Dr. Lee Mills, one of the co-chairs of PTAC. As you may know, PTAC will be issuing a report to the Secretary of HHS that will describe our key findings from this public meeting on targeting improvements in patient safety through alternative payment models. We now have time for the committee to reflect on what we've heard in today's sessions and from the PCDT. We'll hear more from other experts tomorrow in an additional session, but we want to take time to gather our thoughts before adjourning for the day. So committee members, please refer to the potential topics for deliberation document and your notes. To indicate a comment, of course, please flip up your name card. And for Larry online, I'm watching you, so I'll know when you have a comment. And let's try to cover the room thoroughly and get comments out for our staff. So who's first? All right, Krishna.
I thought it was a great day. It was just fantastic to hear the perspectives and many sort of connected thoughts as well. Like each speaker, of course, brought their own worldviews and perspectives, but there was a thread that sort of kept coming through, which I appreciated. One, it was helpful, I think, Anisha's example, even towards the end of modeling it like the health tech ecosystem, I think was a great takeaway for us there. How do we sort of leverage patient safety within the constructs of other collaborations, recent collaborations, so recent in mind. I liked Susanna's point around using the waivers to sort of even create a model or a structure. Loved some of the comments that came about using AI, responsible AI, in order to further the patient safety, whether it's to increase the reporting as well as to help the follow-up. Thought some of these model features could incorporate that. And then some of the bright spots that stood out, particularly Dr. David Klassen's work on that evolution of the trigger tool to automate it, I think are good learnings that we can even incorporate into these models as well. So anyways, I thought that was the connective tissue for me. A lot of good ideas for us to formulate into a model that Abe and team can incorporate with a focus on patient safety.
Thank you, Krishna. David.
Yeah, I think one of the things that I sort of picked up on was this sort of, let's call it the to model or not to model tension today. I think we heard from some folks that came down on the side of we sort of need to adopt the safety in all policies mentality and sort of bake in patient safety in all of these models in some form or fashion. And then I think in the last session we got more of a no, patient safety is distinct and should not be sort of lumped in with quality, but be treated as something sort of entirely separate and worthy of its own study and measurement. And so I think for us as a group, in terms of making recommendations, I think navigating that tension is going to be one of the key challenges coming away from this of do we want to bake in additional patient safety metrics and sort of approaches throughout a litany of CMS programs, or do we want to recommend that there needs to be a patient safety model that comes out of this?
Walter.
Yeah, I agree. This was a great day. A lot of substantive and informative presentations and discussions. It really reinforced to me that patient safety needs to be embedded into APMs as a core objective, or as David just said, maybe perhaps be the primary focus of a model, although I'm not quite sure still how that might work. But regardless, though, I'm convinced even more so that patient safety should not be treated as a secondary afterthought in value-based care models. We heard repeatedly that safety is broader than avoiding obvious adverse events, but it also includes errors of omission, diagnostic errors, communication failures, and unsafe transitions of care across settings. A lot of these things we've talked about before in prior PTAC meetings. Although thinking about all the unintentional harm inflicted upon vulnerable patients by well-meaning clinicians can be downright depressing. We heard many important potential solutions and frameworks from our SMEs that give me optimism. Examples include Sue Sheridan's reminder that patients and families often see safety risks the system can miss, and that PROMs and PREMs can serve as important safety signals to providers. To Jason Mitchell's description of Geisinger's work to become a high reliability organization that enables them to provide a warranty for heart surgeries. To Tahal Gandhi's presentation on how AI has real promise to improve safety by decreasing cognitive burden, identify risk earlier, and make safety problems more visible before they become harm events by measuring the thickness of the ice before the patient falls through it. From a payment model perspective, my big takeaway is that value-based care broadly and advanced payment models specifically have a unique opportunity to make these risks visible and actionable. At the same time, I think one of the most important cautions we heard today from Patrick Romano is that payment models by themselves do not have a strong track record of improving patient safety, but rather this depends on often depends heavily on professionalism, continuous quality improvement, a culture of safety, and a true learning organization. Several speakers also emphasize that a strong safety culture depends on transparency, psychological safety, encouraging clinicians and organizations to report harm events, near misses, unsafe conditions without fear of blame. So I think as I think about tomorrow and our discussion on payment mechanisms, a key question is not simply how to attach financial consequences to patient safety, but how to design payment models that reinforce rather than undermine the intrinsic motivations and safety culture we need. Approaches like no savings without safety or shared savings withholds and earnbacks may have promise, but I think in light of some of the discussions we had this afternoon, they need to be designed carefully so they reward robust reporting, learning, corrective action, and measurable improvement, and align with what matters most to patients, families, and purchasers without encouraging underreporting, risk avoidance, or stinting on care.
Outstanding. Thank you, Walter. Lindsay?
Yeah, I think good comments by my peers already. I think one reflection I've had in thinking through this is we often talk about in payment models how the total cost of care is the gold standard, or we're looking at outcomes and not just process measures. But some of what I heard today actually reflects that maybe it's the process measures and systems that are more important than the outcomes to drive that culture ultimately, as opposed to just penalizing for bad outcomes. Another comment that struck me was along the line of, putting too much money on the line can sometimes incentivize the wrong things and encourage gaming. And as we would think about how some of this fits in payment models, I worry some of the same things could come true when it's thought of as a payment model as opposed to a different approach. So inherently linking payment to it, or a payment model that might try to demonstrate it, might inherently subvert the objectives we're trying to solve for. I think I'm also struck by the comment just around, payment models haven't done a great job in the past, so we need to be thoughtful of it. Yet in every presentation, it is clear that funding or payment is needed. I don't know if it's a payment model or if it's a different type of investment in tools and systems that support that culture of safety, the things like the AI, EHR investment, and human factors designs that could move the needle more than payment models.
Thank you, Lindsay. Larry?
Well, I've got my top 10 just like everybody else, I think, but I don't want to be replicative of what everybody said about structural measures. And, we heard errors of omission. We actually said it in Chinny's presentation are probably more significant than those of commission. heard clearly that we need to move out of the hospital environment to the ambulatory environment so that we can get more of a longitudinal view. We also heard that this is going to be difficult to build statistics from since the numbers fall very rapidly, but the longitudinal care is really what's going to be important. An interesting comment from one of the presenters was that the results of, without a longitudinal, we're not going to find some of these errors because the results of errors sometimes don't show up till quite a bit later. I like the comments around the fact that we need to address the provider experience. I think we need to stop using the term error and try to build some type of a positive improving a safety quotient, something like that. Because as long as we're punitive and negative on what we're finding, we're going to kill the culture. Because I think our biggest challenge here is to instill a culture of change. We could take some learning from the aerospace industry. I mean, the airlines. I mean, my God, nobody is more scrutinized than the airline industry, and they've accepted it. But we're seeing it all around us. I mentioned police having cameras, and now we even have electronic baseball umpires, and it's technology is affecting all of us all around. And I was encouraged to hear from the presenters today that the technology is there to promote and sustain the change that we need. It's there. We've got to build the culture to accept it and inject AI into it, integrating it in, but seriously monitoring it as we integrate it to make sure it's not prone to its errors. And maybe we need to learn from some of these other industries and be incremental in our deployment of this so we don't get the pushback that we would if we're too intrusive. The providers need tools. They don't need more regulation. They need things that help them complete their work every day. I like Chopra's suggestion. This could be something that could be the structure of our of our report to the secretary, that we need to bring the EHR vendors together, but we also need to bring together those that are going to implement those EHRs and those that are going to pay for those EHRs in order to build a solution that we can incrementally deploy and build this culture of change. It was a great sessions today.
At the risk of being somewhat repetitive, I'll try to go fast, but I summarized the day for myself in a structure that I thought about. The first being, it's vertical, and the first being data and infrastructure. And Anish spoke to needing to standardize it, make it easier for people to access, and not making, and have CMS really drive that, right? And have it be an interoperable data layer. This comes up all the time, just as important for safety. The second was really in EHR and being more provider and patient-centric versus just being a tool that adds more burden, because having increased documentation burden also leads to safety risk. There's a cognitive burden there. And I think that responsibility needs to be a part of whatever we design. The third is when Suzanne really spoke about collaboration and how they're designing structures under her watch of coordination, care coordination and collaboration as a part of some of the work that she's doing at CMS. Fourth is really thinking about how does the tactical culture of the provider group. So Tejal brought up leadership. Michelle brought up training. I think we didn't speak about the fact that we need to have an incentive and structure around people being trained in safety. I loved Jason and how he brought up the fact that I love his thought around, hey, don't punish the providers. Let's talk about shared savings. Let's just not have them take a pay cut, because that's what this looks like when you really think about mandatory measures. When we speak to measurement, I thought Clayson hit it out of the ballpark with the fact that part of the problem is we are not measuring what needs to be measured, and the current measures, we seem to be improving, but in aggregate, we're not improving. And maybe the problem why we're not improving is that we're not measuring what we need to, and it's only a percentage, the PSI. And Terry brought up systems engineering, and I think, every system, I think we as a committee need to really think about how we incentivize that kind of tactical, on-the-ground FTE, and how does that become a part of what we create an incentive structure. We have quality officers all over the country now. How many people have safety officers? And so the last, and I would say kind of the most important thing in my mind that came out of all this is that the patient needs to be a big part of the reporting structure. And, Press Ganey does this really well. And back when I was at DuPage, we looked at Press Ganey reports, and it's just patients, if you listen hard enough, will tell you what the near misses are. And there's not a systematized mechanism right now in our infrastructure to pick up on that, measure it, and react to it and have accountability for it. And I think that's important. So I'll stop here.
Okay, great comments and review. I've tried to pick out a few items that haven't yet been picked up. Some of them have. First, to David's prior comment about is safety, part of mandatory every model, or is it a unique model? And I think my response at the end of the day is it's a yes and question, not an either or question, that we ought to bake safety, measurement, incentive, and concepts across the board into everything that CMS and CMMI do. But there may be a place and a space, especially on a pilot for a new approaches for a specific patient safety model, and so that has some merit. I really love the parts about adding PROM and PRIMs to be expected to be a standard part of the data set when you're doing any type of experiencing, measuring, or quality data reporting. And I think that makes good sense. We all are doing, whatever your vendor is, Press Ganey or any other, we're all doing patient experience and monitoring all the time, and yet we're not using some of those standardized questions that could get at some of those domains, and that would be valuable. Must admit, I'm still in cognitive dissonance about this idea that patient safety is not quality, and I get it. From a pure academic discipline, they have different ramifications, and yet at the same time, if you show me a patient safety problem, I'll show you a low-value, low-quality care issue, and so they really are the same. And I think the hook maybe is for most practicing clinicians. We spend a whole lot of time thinking about improving clinical quality, but never think of that in the same vein as a overt safety issue. If you didn't get those last 10 patients to have their cancer screening, you hurt somebody just as surely as if you mopped and didn't put out a sign and they fell and hit their head, right? So I think maybe that duality is more useful with clinicians than with the wider audience. We heard some about mechanisms that Lindsay touched on, that shared savings may be a vehicle. There may be some need for initial investment to increase process and capability performance. That made sense. In the second panel, we heard a lot about that it's really important that we have to make it not cheaper to take the penalty than it is to implement the safety program. And so again, that's a great systems theory. You've got to make it hard to do the wrong thing and easy to do the right thing. And if right now it's just too easy for a CFO to say, I'll take the penalty and not build the systems, we've got to change that incentive structure. But that then led me to a 5,000-foot level, and we've had this conversation multiple times, that really we spend a lot of time talking about models and metrics and measurement and incentives in our minds, all thinking about making the pitch to practicing clinicians to do these. And actually, sometimes the pitch is really to the employment CEOs and CFOs that are running big integrated health systems and employing physicians across the country, right? So in a sense that this safety issue is, as most safety issues come up in integrated health delivery systems now, they often disappear into risk management and never see the light of day. And so it makes me think that we need the chief counsels and the compliance officers and the risk safety community to be part of the conversation to solve this, that they've got to have a different culture of how we take this on. All right. Emphasized a powerful point. And then lastly,
may I have your attention, please?
okay. And lastly, what we heard loud and clear this afternoon, which is kind of a first in 6 years in the PTAC, is that it's not a technology issue. It's not an information issue. It's not a regulatory framework, policy, or legal space issue. It's just a willpower issue. All the preconditions we need to do something really, really special already exist. It's just a matter of lining up the dots, build the system, and get it released. And that's an exciting place to be for the group. So,
Not a funding issue.
okay. Other final comments or thoughts? Okay. Well, at this time, I want to thank everybody for participating today, both our wonderful session experts, my PTAC colleagues, and all those who joined us in the audience today, both in person and online. Thank you for that. We'll be back again tomorrow morning at 9 a.m. Eastern Time, where we'll be joined by 4 incredible experts who will share their perspectives during another expert session on payment mechanisms and financial incentives to encourage patient safety in alternative payment mechanisms. There will be an opportunity for public comments related to the meeting topic tomorrow morning at approximately 10:50 Eastern Time before the meeting concludes. And I believe at this time we have 4 public commenters signed up. Look forward to hearing their comments. We hope you will join us then. Thank you. And this meeting is adjourned for the day.
Produced by the U.S. Department of Health and Human Services.